Thank you everyone for joining us today. It is my pleasure to moderate this session dedicated to growing pain, as Ivan said. Um, and I'm happy to say that we have almost 800 registered attendees for this session, which is makes me really proud. We try to assemble a high-level lineup of speakers, and we will show you a part of work that we did in Aspetar Sports Growing Pain Center since its establishment in 2012. Uh, and the majority of people here are part of this group from the beginning, and we're proud of some of nice results that we did. Our first speaker for today uh, is Dr. Adam Weir, uh, authority on growing pain in athletes, a sports medicine physician with a PhD in this topic. And he was the first clinical lead of Aspetar Sports Growing Pain Center 8 years ago. And it is my pleasure to present him to you today. And Adam, please, the floor is yours.
Okay, thank you very much, Sarko, for the kind introduction, and it's a pleasure and honor to be with you all the way from Holland today. A fantastic opportunity to present the work of our team, and I'm going to be speaking today about groin pain in athletes, the diagnosis, the past, the present, and the future. So I'll just start up my presentation here. There we go. Um, So we're going to look back, look at where we are now, and then look where we're headed in the future in terms of the diagnosis of growing pain in athletes. Before we start, I just want to express my thanks and gratitude to the research team at Aspetar over the years since I joined in 2013. Very proud of a lot of the achievements we've made, and with all my colleagues and friends here in Holland as well, and take this opportunity to give a special congratulations to Dr. Popovic and the team on the publication of the Aspetar Sports Medicine Collection. A fantastic achievement. Very proud and happy to have made a small part of this. And I appreciate the huge amount of work that's gone into this. And it's nice to have today as a special occasion to celebrate this. So if we think about the past, the present, and the future, and we start looking back, there are some nice historical articles in the book. And when we look at groin pain, let's start just by considering a simple clinical case. So if we consider a 21-year-old healthy football player with an 8-week gradual onset of groin pain, he feels the pain on sprinting and on changing directions when he's playing, and he feels the pain at the insertion of the right adductors. When we examine the player in clinic, lumbar spine and hips is unremarkable, and you can find his recognizable injury pain when you palpate the insertion of the adductors on the right with resisted adduction testing, and there's also some tightness and pain when you stretch the adductors on the right. Examination of the inguinal canal and the iliopsoas is unremarkable. And just think for yourselves, what would you call this diagnosis in your clinical practice if you saw this football player tomorrow? And again, a second simple clinical case, 31-year-old professional soccer player, gradual onset pain since the last 10 weeks. Pain is felt in the inguinal canal region, and because of the pain, he's unable to be able to sprint or to shoot with full speed. On clinical examination, hip joint and lumbar spine, normal pain-free motion. And on palpation of the inguinal canal, you can find the recognizable injury pain, but there's no palpable inguinal hernia. And when we do resisted abdominal muscle testing, this also provokes his pain in the left inguinal canal. And again here, think for yourself, what name would you give to this diagnosis in your clinical practice? And when we look back, it was clear there was a lot of confusion surrounding this. We did a study where we sent these two clinical cases to 23 experts from around the world, sports medicine physicians like myself, surgeons like Sarko, sports physiotherapists, orthopedic surgeons, and we got a surprising answer. For one simple clinical case, 23 experts, this is the first case, they used 18 different terms. And the second case, the pain felt in the inguinal canal without an inguinal hernia, 23 experts, 22 different terms. Sportman hernia, incipient hernia, inguinal disruption, posterior wall weakness, Gilmore groin, you name it. So a real high number of different terms used to describe a simple clinical presentation. And the question is, does this matter? Well, I think it does for a number of reasons. Firstly, it's really impeding communication between healthcare providers. So often when we discuss cases, if we use different terms, we're talking at cross purposes. And perhaps more importantly, the terms we use to describe a diagnosis influences what patients think they need to get better. So what we name these conditions is really important for athletes to think about their treatments. And this is one of the reasons that groin pain is said to be complex. So yes, we have a complex anatomy, lots of different anatomical structures, organ systems all contained within the groin. But one of the reasons that we think groin pain is complex is because we've come up with so many terms as a medical profession over the years to describe simple clinical presentations, and that's made it Babylonian. So we set out to try and do something about this. We invited the 23 experts, and there were some systems already in place. Per Holmich back in 2007 published a study using a clinical entity approach. And in the book chapter, there's a nice article written by him on groin pain in football players with a systematic diagnostic approach. And Per was at this time the head of the Groin Pain Center. And we convened the World Conference on Groin Pain in Athletes back in 2014 and held a consensus meeting, the Doha Agreement meeting on terminology and definitions for groin pain in athletes. The 23 experts participated. What's interesting, when you line them up and ask them to pose for the photo, it becomes quite easy to spot who were the football players or who played in the past. And the Doha Agreement meeting was published in 2015 in the British Journal of Sports Medicine. This was a proud moment for me and for the team at Aspetar to put out an international consensus statement on groin pain in athletes. And the consensus statement that includes 4 defined clinical entities: adductor related, iliopsoas related, inguinal and pubic related. We also wanted to stress that the hip is an important cause of groin pain in athletes, and Dr. Rinchu Agricola is talking about this later on today, and that other things can cause pain in the groin, and I come back to this in the present section. So some considerations: this is applying to long-standing groin pain. It's a clinically based system that works around clinical entities. At the current time, there's a lot of confusion and debate about the meaning and potential underlying pathology. And don't forget that multiple clinical entities are possible. And we found in a series of 100 patients who presented to Groin Clinic in Aspetar that 44% had more than one clinical entity. So bear this in mind when you're examining your athletes. We also agreed some terms not to be used. Osteitis pubis, for example, there are some studies done showing that it's not an inflammatory condition. So this is an incorrect nomenclature. And sports hernia as well, there is no hernia. So we felt that these kind of terms were incorrect and agreed as a group not to use these terms anymore. So that's where we're coming from. Confusion. Where are we now? The present situation. So in clinical practice at the moment, we're using the Doha agreement system for classifying groin pain in athletes. And so the first case, the football player with pain on the adductor insertion, you can find the pain with palpation and reproduce the recognizable injury pain on resisted adduction testing. Then we call this adductor-related groin pain. The second case, pain in the inguinal canal region with recognizable pain on palpation without there being an inguinal hernia. And this is more likely if there's pain on valsalva or unresisted abdominal muscle testing. This is then inguinal related groin pain. And it's important when you're examining athletes to understand the anatomy. Now, we British people obviously have some kind of fascination with the anatomy. And we've written together with Andreas Cerner, who's presenting later today, Andrea Mosler, and Sarko, we wrote an overview article that's also contained within the chapter, where we bring together anatomy, clinical examination techniques, and the Doha agreement meeting terminology. This is just an example, and I'm not going to run through it all today. I just want to point you towards this article as a free resource that I think can be meaningful and useful in your clinical practice. So this is to steer you towards that. Just wanted to stress that other things other than these musculotendinous problems can cause pain in the groin. Dr. Agricola is talking about the hip later on, and other causes too. We've seen in groin clinic in Aspetar many cases with nerve entrapment around the groin, or cases where athletes have an actual symptomatic inguinal hernia. So these are important considerations. There can also be even more sinister things going on in the groin. And I just wanted to share one red flag from clinical practice. So when athletes present with pain at night, even after stopping doing sports for some days or weeks, and it's a pain that wakes them up, and it's not just a pain on rolling over in bed or sitting up or lying on it, I'd consider this to be a red flag in clinical practice. And from the past 12 months in the groin clinic here in Holland, a case here at the top of a young athlete who had a lymphoma in his pelvis, and of a male runner who turned out to have Paget's disease in his femur here at the bottom. So it's important that we don't lose sight of the broad differential diagnosis when considering long-standing groin pain in athletes. Now, alongside the work of long-standing groin pain, I'd like to give a special thanks to Andreas Cerner and the rest of the team for the amazing job they've been doing looking at acute onset, so the diagnosis of acute groin injuries in athletes. The link here to Andreas's PhD thesis, which is available free online. And for this, Andreas gathered data on more than 100 athletes who presented with acute groin pain that occurred during sport. What we found is that kicking is the most common injury mechanism in football, and that changing direction is the most common acute groin injury mechanism in other sports. 2/3 of the acute groin injuries are located in the adductor muscle group, of which 90% affect the adductor longus. And 1/3 of the acute groin injuries affect the hip flexors. And there it's about a 50-50 split between the proximal rectus femoris and the iliopsoas muscles. And because adductor longus accounts for the majority of acute groin injuries in athletes, let's focus on that a little more. We looked at the location of injuries, and what we saw is that in acute adductor injuries, 26% of the injuries are located proximally, so where the tendon joins the bone. And that what we saw in those cases is that 3/4 of the time, there was actually a complete rupture of the proximal adductor longus tendon. The other cases were located at the musculotendinous junction, and these were less severe in terms of their injury grade. So beware these proximal adductor injuries because they are often a complete rupture. We also looked to see if clinical examination can be useful in diagnosing these acute adductor injuries, and it can. So clinical examination can locate injuries in the adductors, and importantly, for those of you who don't have ready or easy access to imaging, then clinical examination, like the lack of pain on palpation, is very valuable in ruling out significant injuries with a very high negative predictive value. So if you palpate everywhere and you can't find any recognizable injury pain, we can have a high level of confidence that there's no injury in the adductors. So this is clinically useful information coming out that's affecting our clinical practice at the present time. And it's also important in terms of the prognosis. So proximal adductor longus injuries are taking a lot longer to recover and return to sports than those at the musculotendinous junction. So these different locations have important implications for the prognosis. So that's where we are at the current time. In long-standing cases, we're using the Doha classification system, and we have new valuable information that's helping inform our clinical practice for diagnosing acute groin injuries. So if we look forwards, what does the future hold? Well, at the moment, we have a number of really nice studies going on. We have one where athletes who come into the groin clinic are examined clinically by Zarko and Andreas, and also undergo additional imaging. Javier is helping us with that, one of the musculoskeletal radiologists at Aspetar. And they all perform these examinations blinded to each other. And this whole process is being adjudicated by Willem Heijboord, our current PhD student, who's doing his PhD thesis on this. And this should give us some more valuable information looking forward about possible tissue diagnoses. And Willem's also been doing some work on the uptake of the Doha agreement in clinical practice in the world at large, but I'm not going to talk to that because Willem's the next speaker and he'll be presenting new data on that. But that's something that I think will be really important and I'm proud of moving forwards. Another interesting thing would be adolescents with groin pain. So if we go back to the first case, the 28-year-old healthy football player, pain at the right adductor insertion with a gradual onset. And we just changed the fact that he's now 17 years old. So a teenager who's already had his growing spurt, what would be our diagnosis here? Now, this is a case from clinical practice, 17-year-old healthy football player, top level. On the X-ray of his pelvis, we can see here a small fragment around the insertion of the adductor with some sclerosis and an irregular joint surface more marked on the right. He also underwent an MRI examination. These are axial sequences which are fluid sensitive, so fluid is white. And we can see here the short arrow is some edema in the pubic bone, and the long arrow is an oblique fluid line located within the pubic bone. Now, in my experience, these cases are often reported as having osteitis pubis, but that's not the case. A nice article from 2015 here. If we look at the development of the normal healthy pubic apophysis, so these are CT scans, also in the axial plane. And if you look at picture number 1, you can see that the front of the pubic joint is rounded and that the bone surface is irregular, and that this is all still made of cartilage in front of that, which needs to ossify. In picture 2, you can see the bone island, so the ossification center, where that cartilage is starting to ossify. And in picture 3, you can see the normal adult configuration, where the pubic joint is properly squared off, as it looks like later in life. What's interesting is the age at which this bone island is present, and that's normally between the ages of 15 and 21. And in fact, the pubic apophysis, along with the iliac crest, is one of the last apophyses in the human body that fuses. And if we go back and reconsider our 17-year-old football player, he actually has an apophysitis. So we're all familiar with Sever's disease in the heel and Osgood-Schlatter in the knee. This is a pubic apophysitis. The question is this something really rare? And we have great new data coming out from Olivier Matern, who's doing his PhD on this, a physiotherapist working at the Aspire Academy, where they collected data for 4 seasons on more than 500 players. And this is just out in the British Journal of Sports Medicine. And what they saw was that hip and groin injuries are one of the most common groin injuries also in youth soccer, and that the number one cause of hip and groin injuries in youth soccer, apophyseal osteochondrosis, so apophyseal apophysitis, is the most common cause of time loss injuries in youth soccer. So this is important in our clinical practice, and Olivier has a number of new papers on the way that will hopefully come out this year. So to wrap it all up, groin pain world was confusing and Babylonian, with lots of different terms being used to describe the same simple clinical presentation. At the moment in clinical practice, we're using the Doha agreement meeting to describe the diagnosis for long-standing groin pain. We have new knowledge about acute groin injuries. Beware the proximal adductor injuries. These can be avulsions which take longer to recover in clinical practice. And looking forwards towards the future, new studies coming from Willem Heibor with his PhD, and also work on pubic apophysitis from Olivier. So thanks once again, Shukran, for the invitation. Fantastic to be part of today's event, and thanks to Dr. Popovic and the journal team for their continued support for the Sports Groin Pain Center over the years. It's been a great journey, and I'll just sign out.
Okay, thank you, Adam, for a wonderful presentation as always. We could see the importance of using common terminology and speaking the same language when we communicate with the patients and our colleagues. We could see that there are 4 entities that we described in the Doha Consensus 2014-15. Inguinal, adductor, iliopsoas, pubic, with closely related hip and other causes. Now, our next speaker is our PhD candidate, physiotherapist William Heiboer, who is doing his PhD on clinical diagnosis on groin pain, but also did a study on validation and adoption of the Doha Consensus from 2015 with a questionnaire sent to different centers, and he will tell us a little bit more about that. So, William, the floor is yours.
Hello, everyone, and thank you, Zarko, for the kind introduction and for inviting me to this lecture to present our work, where we evaluated the adoption and evaluation of the Doha Agreement classification in clinical practice. So in the next 10 minutes, I will share with you the main findings of our study. And just to shortly recap of what Adam already told us, we know that diagnosing groin pain is difficult, not only because of the complex anatomy, but also the confusing terminology. And this was shown nicely in the Delphi study that was performed as part of the Doha agreement process, where 23 groin experts reported 18 to 22 different terms for 2 presented clinical cases. We know that diagnostic terminology matters. From this systematic review, we know that if clinicians use more medicalized or precise terms, that there's a general shift towards more invasive management and higher anxiety ratings perceived by patients. And if we relate this back to the groin, these are just 4 of the terms that were reported by the experts for a case with pain in the adductor area. And you can imagine that patients may respond differently if they heard a diagnosis, adductor-related groin pain, osteitis pubis, or adductor tenoosseous defect. The Doha agreement aimed to solve this problem, and during the past 5 years, they gained a lot of academic interest, with currently already over 200 citations. But we don't know if clinicians adopted the classification system in their clinical practice, and if they feel it could be improved. And that's what we aim to investigate. And we mainly focused on the 4 defined clinical entities of groin pain. What we did is that we performed 2 sub-studies. We performed a 2-round Delphi study among the original Doha agreement offer group, and we performed an e-survey among clinicians treating athletes with groin pain at the FIFA Medical Centers of Excellence and IOC research centers. And for this talk, I will mainly focus on the adoption part of the Doha agreement. So if we look at the respondents, we had 23 out of the 24 original Doha agreement experts that responded to the Delphi study. And we had 51 clinicians responding to the e-survey. So these are the clinicians working at the FIFA and IOC centers. And as you can see over here is that they came from various different countries, and they also had multidisciplinary backgrounds. So we first asked the original Doha agreement offer group if they adopted the Doha agreement classification in 4 different parts of their practice, in their communication with patients, with colleagues, in research, and in teaching. And what we found is that 73 to 82% reported to always or often use the Doha agreement classification. But interestingly, also 9 to 18% of the clinicians, so 2 to 4 of the clinicians reported to rarely or never use it. And the main reason by this last group for not using the Doha agreement classification is that they feel the entity approach is not specific enough for them. We also asked the clinicians working at the FIFA and IOC centers if they use any classification system in their clinical practice. And I think it's good to highlight that during the past 10 years, at least 3 consensus statements appeared that aim to resolve the diagnostic terminology problem in groin pain in athletes. And of the 51 clinicians that responded to the e-survey, 57% reported that they use the Doha agreement, 29% reported that they don't use any classification system in their clinical practice, and the remaining 14% reported that they use a combination of classification systems. And of this 14%, 12% also uses the Doha agreement as part of their personal combination of classification system. So we can say that also in this independent group of clinicians, that the Doha agreement has been widely adopted. If we look closer to the 29% of clinicians that responded to don't use any recommendations of available consensus statements, is that 13.5% responded that they don't know any of the classification systems, and 11.5% responded that they know them, but they prefer a different approach. So in other words, 1 in every 7 clinicians that treat athletes with groin pain is not aware of the consensus statements that address the diagnostic terminology problem. And 1 in every 8 clinicians knows them but prefers a different approach. And this highlights, we think, the importance of appropriate dissemination of consensus statements, but also evaluating the recommendations over time. Because you may find out that some clinicians don't find your recommendations useful in clinical practice, or that it could be improved. The second part of our study was more or less a replication of the 2015 Delphi, so where clinical cases were presented and the clinicians were asked to provide the terms that they would use for their most likely diagnosis. And if we look again back to the 2015 Delphi, we had the 23 groin experts over there that reported 9 to 11 different terms for each clinical case as the most likely diagnosis. And the Doha Agreement specific terminology was being used by 26 to 39% of the clinicians. The same group, now in our Delphi study, still provided 8 to 11 different terms for each clinical case for the most likely diagnosis. But now the Doha Agreement specific terminology was used by 50 to 67% of clinicians. E-survey, we saw that the 51 clinicians provided 12 to 15 different terms for each clinical case for the first most likely diagnosis. And the Doha Agreement terminology was used by 43 to 55% of clinicians. So what we see over here again is that the Doha Agreement specific terminology is used by the majority of clinicians, but there's still a variety of different diagnostic terms being used by clinicians. That these are mainly the clinicians then that don't use the Doha Agreement specific terminology. And this is just one example of one of the cases. This was a case with long-standing groin pain in the lower abdominal area, more specifically in the left inguinal canal area. And these are the results of the e-survey, so the 51 clinicians that provided the first most likely diagnosis for this case. We see that they provided 15 different diagnostic terms, where inguinal-related groin pain was the most chosen term by 43% of clinicians. But interestingly, sportsman's hernia was the second most used term by these clinicians. And as we already heard from Adam as well, is that this term is actually being discouraged because an actual hernia is rarely present in athletes. So just to summarize, the Doha Agreement classification system has been widely adopted, not only in the original author group, but also by an independent group of clinicians. And we think this shows a good clinical utility of the classification system, and it can help us clinicians in a unified communication among each other when we talk about a diagnosis for groin pain in athletes. There is, however, still considerable heterogeneity in diagnostic terminology when clinical cases are presented. And 1 in every 4 clinicians is not aware of any recommendations of consensus statements on diagnostic terminology in groin pain in athletes, or they prefer not to use them. And we think, therefore, that future consensus statements should at least include a knowledge transfer and dissemination plan, and they should evaluate their recommendations over time. Lastly, I would like to acknowledge this great group of authors for guiding me throughout the process of this study, and also, of course, all participants that took the time to fill in the Delphi survey or the e-survey. Thank you very much.
Thank you, William, for a nice presentation, and thank you for all the hard work that you did in gathering all this data. We could see that terminology is still an issue when it comes to groin pain, that we are using different language when we treat our patients. We could see that 50% of people that were in this study, the medical professionals, are using Doha Agreement. But we also know that there was like you mentioned, there was a British consensus statement by my dear friend Ali Sheen from 2012, published in 2014, and then there was another one from Giannicola Bisciotti, who is our collaborator also with Italian consensus. The moving forward would be to gather people as a group together and from different centers and try to make this better and convince the 25% of the people who are not using the consensus statements to at least try to use a common terminology, which will help us in the studies, comparing results, but also in everyday work. So we could also see that hip was mentioned a few times here. It was closely related to groin pain and the 4 entities that we mentioned. That is why our next speaker is a rising star on the sky of orthopedics hip surgery for athletes, Dr. Rince Agricola, with a PhD in hip pathology. So, Rince, the floor is yours.
Thank you, Zarko, for this introduction, and I'm really happy to be back in Aspetar in Doha again, and it's a pleasure to be involved in this session and to talk about the hip. We today already heard some nice talks about the groin, terminology, anatomy, and surgery. And now I want to dive a little bit deeper into the groin, like to the hip, with a special focus on FAI. I don't have any conflicts of interest. And as you have heard in the previous talk, groin pain has been classified into different categories. And a very good paper on this were the Doha Agreement, which defined groin pain into 3 categories. And the first category of groin pain was divided into clinical entities of adductor-related groin pain, iliopsoas, inguinal, and pubic-related groin pain. What they also mentioned in this paper were 2 other categories, and these were hip-related groin pain and a category other. And I'm going to focus on the hip-related groin pain. In the Doha Agreement, they stated that there was agreement that pain from the hip joint should always be considered as a possible cause of groin pain, but it wasn't the scope of the Doha Agreement to reach consensus on hip-related groin pain. And that is why we organized in 2018 a consensus meeting in Zurich on hip-related pain. And we very recently published an infographic on that. And I want to talk you through this infographic really in my presentation. And we're going through this infographic step by step. So a little bit of background. The consensus meeting was in 2018, and there were different experts from different backgrounds. Like there were physiotherapists, orthopedic surgeons, sports medicine practitioners and scientists, biomechanics, and also radiologists involved. So really a lot of people from different backgrounds involved. Before this meeting, we did systematic searches of literature on hip-related pain and the questions we wanted to answer. And then we tried to reach agreement with this whole group. And we did that with the literature. We searched beforehand. Then we had discussion sessions in Zurich. And then we tried to come up with recommendations related to hip-related pain. And let me talk you a little bit through this infographic. For all recommendations, we used the Likert scale from 0 to 9, which indicates the level of consensus we reached on certain recommendations. Let me start with recommendations which were meant for clinicians and for researchers. And here you can see that we reached agreement on how to classify hip-related pain in young, active adults. We reached consensus on classifying hip-related pain into femoral acetabular impingement syndrome, acetabular dysplasia and/or hip instability, and a third category of other conditions. And these are actually conditions of soft tissue injury like labrum, cartilage, or ligamentum teres injuries. Often we see those specific types of conditions like labral lesions or cartilage lesions together with the first 2 entities like femoral acetabular impingement and acetabular dysplasia. Sometimes there's no underlying bony morphological characteristics of femoral acetabular impingement or dysplasia, and then you can classify those people into the other category. So let me focus on femoral acetabular impingement. Here you can see on the left side the normal spherical femoral hip, and in the middle a hip with cam morphology. And during motion of the hip, this cam morphology can impinge into the acetabulum. And this movement, if that occurs, we call it femoral acetabular impingement. But this is a little bit a simplified version of what femoral acetabular impingement is. And in 2016, we held the Warwick Agreement on femoral acetabular impingement syndrome. And as you can see here, we defined femoral acetabular impingement syndrome as a triad of symptoms, signs, and radiological findings. And as you can see here, the radiological findings don't tell you everything, but I will come back to that later. Femoral acetabular impingement syndrome also consists of symptoms and clinical signs, which should all be consistent with the diagnosis of femoral acetabular impingement syndrome. So let me start first with symptoms. Which symptoms are characteristics for FAI syndrome? Mostly people complain of pain deep in the groin or in the hip. And when we did those, it also became apparent that it's pretty cultural defined whether patients will call and say, well, I have groin pain or I have hip pain. That really differed between the countries involved. But it's not only groin or hip pain. As you can see in the figure, the pain can also felt or radiate to the back, buttocks, or thigh. But what's quite typical for femoral acetabular impingement syndrome is that it's a motion or position-related pain. And besides pain, there can also be sensations felt like clicking, catching, locking, stiffness of the hip, or a restricted range of motion of the hip. Then when we go to the clinical signs, the Warwick Agreement defined the presence of FEI syndrome, the clinical signs as a positive Fadir test and restricted range of motion, most typically decreased internal rotation or flexion. But then let's go back to the Zurich Agreement and which recommendations we did there for clinicians. In the Zurich Agreement, the recommendation was a negative flexion adduction internal rotation, or the Fadir test, helps to rule out hip disease. So let me explain the difference. So the Warwick Agreement says FAI syndrome should have a positive Fadir test, while the recommendation in the Zurich Agreement states that a negative Fadir test helps to rule out hip disease or FAI syndrome. Well, can you explain that? Because when we went into the literature, the Fadir test has a really high sensitivity, but also a very low specificity. So that means that people with FAI syndrome often have a positive Fadir test. But also, a positive Fadir test is also very highly prevalent in people without FAI syndrome. So a positive Fadir test doesn't really discriminate between people with and without FAI syndrome. What we also found is that there is only a low shift in probability of diagnosing FAI syndrome before and after the Fadir test. So let me explain that a little bit more and a little bit of background of that literature. First of all, studies looking at this are mostly of quite low quality. But also, those studies mostly are not designed to test the diagnostic accuracy of the Fadir tests. And lastly, they are mostly performed in high volume hip surgeon practices, which means that patients included in those studies already had a very high a priori probability to have FAI syndrome. So a positive test didn't change a lot of that probability after the test. So that's important to take in mind. So for the Zurich Agreement, we made a cautious recommendations that a negative test helps to rule out FAI syndrome in people with hip-related pain. And we couldn't find sufficient evidence on the diagnostic value of restricted range of motion. imaging findings. So that's the third category of the Warwick Agreement. And in the Warwick Agreement, we stated that radiological findings of either CAM or pincer morphology or both should be present to diagnose FAI syndrome. Let's see what the Zurich Agreement recommends for this. First of all, we reached agreement that the diagnostic utility of imaging for hip disease and FAI syndrome in people with hip-related pain is only limited. So that's quite similar to the clinical signs. And imaging should always be combined with the patient's symptoms and signs. And when it comes to imaging, what type of imaging should you use? Then we recommended to start with an AP pelvic view and a lateral femoral hack view. That can be a cross table view, that can be a frog leg view or Don view. It should be a lateral femoral head neck view in the first workup of those patients. And most often you already can see the morphological characteristics you're looking for. You can see a pincer morphology or CAM morphology, but you can also appreciate other types of diseases. When you want to go further and you're interested in the soft tissues like the labrum or the cartilage, we recommend to do the cross-sectional imaging. But for this third point, I won't go in further detail, but I would like to discuss the second point a little bit further. As I said, it's just a little bit similar to the clinical signs. If you look at the symptoms, signs, and radiological findings, all of those in isolation are not really telling you much. You have to combine them. And let me show that with an example. This is a very recent study from the fourth cohort. The fourth cohort is a cohort from Australia, which included both symptomatic and asymptomatic football players. One group of 184 symptomatic players had hip pain and a positive Fadir test, and the control group didn't have hip pain and had a negative Fadir test. And if we then look at the CAM morphology prevalence, we found that the CAM morphology prevalence in males was 78% in the symptomatic group and 76% in the male group. So instead of using the words like sensitivity and specificity, this also gives you a sense that the CAM morphology itself, the presence of CAM morphology itself, can't distinguish people with or without hip pain or positive Fadir test. And if you look then at females, there was a 42% prevalence of CAM morphology in the symptomatic group and a 25% prevalence in the asymptomatic group. And this wasn't a statistically significant difference. So also in females, the presence of CAM morphology couldn't distinguish symptomatic and asymptomatic football players. And this was a unique study because it didn't only look at hip pain, but it also looked at people with a positive Fadir test. And also in that group, the imaging alone wasn't sufficient to distinguish those groups. And this is actually in line with most of the cross-sectional studies on this topic. And if you look at the prospective studies on this topic, we see a little bit of conflicting results. One study published by Van Klei et al. Showed that large CAM morphology at baseline was associated with hip and groin pain after 5 years, but not with the Hagos after 5 years. Another study showed that a CAM morphology at baseline was associated with hip pain after 4.5 years. So they showed a positive association. But again, another study from Doha, actually, from Andrea Mosler, showed that CAM morphology at baseline was not associated with future hip and groin injury, which were actually mostly adductor-related injuries, within 2 years. So also prospective studies really show a little bit of conflicting results. And if they show a positive association between CAM morphology and hip pain, then it's only a weak association and only in a small subset of people. And interestingly, this is very different from the association between imaging findings like chem morphology and osteoarthritis, because chem morphology on imaging is consistently associated with the development of hip osteoarthritis in prospective studies. And also, a greater alpha angle on imaging is associated with a higher risk of OA in the future. And this is also be shown by Josh Harry, again the fourth cohort. And this figure needs a little bit of explanation. Here you can see a hip joint. So this is the femoral head. And here you can see the acetabulum. And they scored the cartilage defects, green, completely green, 0%, no cartilage defects, to 100%. And if we then first look at hips without chem morphology, we only see a small percentage of football players that had cartilage defects. But if we then look at people with chem morphology, we showed that especially in the superolateral subregion of the acetabulum, so particularly there where the chem morphology enters the acetabulum, we found a higher prevalence of cartilage damage. And in people with a large chem morphology, this percentage was even higher. So also in the fourth cohort, there was an association between chem morphology and cartilage damage. And also the bigger the chem morphology, the more the cartilage damage. So there's really a discrepancy. While we see this with chem morphology and cartilage damage or osteoarthritis, we really don't see this with chem morphology and hip pain. So there's something that we still not fully understand. So let me get back to this simplified image. Here you can see a chem morphology again that can cause impingement within the acetabulum. And we know from surgery that even very young people can present like this with very severe cartilage damage. And we know that the chem is associated with that, but it's probably only a very small subset of people with a chem and with femoral acetabulum that go onto this kind of cartilage damage. But up till now, we really can't predict who is going to develop this cartilage damage and who is not. So this brings me to the take-home messages of today. In young active adults with hip-related pain, comprehensive examinations of symptoms, signs, and imaging findings is needed, and a combination of those can lead you to the diagnosis of FEI syndrome, dysplasia, or other. All of those examinations in isolations can't really discriminate between the diagnoses. So you really need the symptoms, the signs, and the imaging findings together. And then you can categorize people with hip-related pain into FEI syndrome, dysplasia, or other. Thank you very much.
Thank you, Rinche, for a fantastic presentation. Thank you for highlighting the HIP 2018 consensus, also for showing us that when it comes to hip pain and groin pain, you need to do the hip examination always to rule it out. And even if the tests are not so sensitive, it's not so specific, but they're sensitive in detecting hip pain. So if the tests are negative, you can focus on other entities. We could also have we had some technical difficulties, but this is we're living in strange times now, and online conferences, etc., is much better with the audience, and probably it's much more difficult to talk in the empty auditorium than to play football in an empty stadium. So our next speaker for today is my dear friend Andreas Cerner, physiotherapist with a PhD in groin pain in athletes. I'm proud to say we work together on a daily basis, share a lot of patients, and he's a guy with very passionate for football, groin pain, and family. So he will tell us something about conservative treatment when it comes to groin pain, as much as he can during 20 minutes. Please, Andres.
Thank you very much, Sarko. It's really a pleasure here to talk about groin pain as part of this sports medicine collection forum. As you said, it would have been nicer if we had time to chat in the breaks and before and after, but unfortunately we have to look forward to that. But still, I'll go through a few things. I only have 20 minutes, so I'll keep it fairly broad and focus on defined clinical entities mainly, so not concerning hip-related groin pain, but looking more from a broader perspective on how we approach it in terms of what we see often goes wrong in the focus of the rehabilitation. But if we first look at the evidence, there's a lot of systematic reviews on the treatment of groin pain, a lot of studies. These systematic reviews will include from 2 to 72 articles. We did one of those as well. But it seems like there's a consistency in the articles that are actually usable to make recommendations. And in our review, we found that there were only 4 high-quality studies and that we can give some form of recommendation from. And I'll just summarize that really quickly because what we know from that is that there's moderate evidence that exercise is not only better but a lot better than passive treatment. And we see mainly one exercise protocol, the Holmig protocol from '99, being used in many different studies, and 2 RCTs, also a multimodal program involving manual therapy and running progression, shows that this has good results for adductor-related groin pain. And what we can expect is return to sports race using these protocols from 50 to 87%, and the duration will take you about 3 to 4 months, so 12 to 18 weeks on average. What we also see is that surgery actually appears to work well, so there's some moderate evidence for that in cases where the rehabilitation fails. In an RCT on inguinal-related groin pain, we saw that laparoscopic treatment actually was better than this modified protocol, and that after 3 months, 90% of players had returned to sport. Similar for adductor tenotomy in this prospective study, we saw that almost all players, more than 40 players, returned to sport again and did so in around 9 weeks. So not too bad for those either. But we always want to start with the rehab, and a basic thing in rehab is progressive loading. So we're going to find a starting point and we're going to progress continuously, and we may do so in different ways, and I'll go through some of the things that we consider in that regard. But first we need to know when there's an injury, because groin pain is so common in many sports, specifically football. So it's sometimes hard to determine when we consider this an injury, because many players will play with pain and it will resolve by itself or by small modifications. And there is a simple squeeze test, the Copenhagen 5-second squeeze test, which is shown to be correlated with self-reported function and symptoms. So if you just do a simple squeeze against a partner's arm and ask for a pain in 0 to 10 scale, if the player reports 0 to 2, he can probably have a green light and continue playing. If he reports 3 to 5, you have to really be attentive that this will not get worse, and really do some modification. And if there's reports of 6 to 10 out of pain, it is corresponding to considerable reductions in performance or in self-reported symptoms, at least, and they should not be playing if they haven't already stopped. So we'll focus a little bit on the last group and players that have stopped playing. So the next question is then, how long is it going to take for these players? And as I just told you, research will tell you that we're looking at about 3 to 4 months. So when we tell the player that, he may not be too happy, especially if he just recently realized that he couldn't continue playing. But there are plenty of players who will be out of play for a very long time. If you're working in an elite sport or just in general, you may, as a physiotherapist, say, we want to choose the safest, and you want to recommend close to 4 months potentially as an expected timeline. But if you're working in a elite sport and if there is some pressure around you, or maybe from the player, maybe from the coach, they will probably look strange at you and say, he was recently playing, why can he not get back sooner? And that will put some pressure on you to reduce this timeline. So as a physio, you have to make different choices on how you want to do that. What we often see is that people start from the bottom and then make really big steps along the way. And any given time along that along those progressions, you can end up with an exacerbation of pain, and you have to start over. And those are the ones that often end up in failed rehabilitation courses. We also see players who start at a very, very low level and stay there for a very, very long time. And then as the time is ticking, the expectations of a return to sport increases. So in the end of the rehab, you have to make really big progressions in order to get the player back. What we do here is try to find the highest level that the player can start on. So that would be individual, but the higher that we can start the player on initially in the treatment, and the closer we are to the level that is required as a return to sport. And there may be some cases where we're getting close to that and have to make a shared decision on how much risk is acceptable in terms of re-injury risk, recurrence risk. But we hope that we can cut down time quite significantly, and we feel that we can. So if we go a little bit more into what matters in the rehab, we have a general rehabilitation progression or principles of general progression of load. And then we'd have to make individual adjustments to that. So that always happens. We have to adjust to the type of sport the player is getting back to, possibly even to the playing positions, whether it's elite and recreational, and there are many other things that you have to account for when you adjust your treatment protocol. We're building up, and what we want to do here, we want to build up differently, because if we're only looking at one parameter, we may be limiting ourselves. So what we do is that we divide our rehabilitation progression into different focus areas. We want to look at the painful structure and build up on that. We want to look at function, and we want to look at some general training. Our general training we generally divide into two as well, with anterior chain focus and a posterior chain focus, and usually with the players here we'll do that on separate days. And as we experience, players are able to start at very different levels, and that varies very much individually. For instance, if we focus on adductor-related groin pain, which is the most common, players may be very, very painful when we're isolating the muscle and loading the specific muscle, but they may actually be able to run linearly, completely pain-free. So we want to, usually we want to start them at that level as well. If we're looking at synergist functions, we're focusing on anterior chain exercises, which are usually also limited because they often involve the painful structure in some form. But when we're looking at the posterior chain muscles, most players can start very, very high and often at a normal level without any problems. So even though you have a player lying down and doing squeezes when you're doing isolated loading, that doesn't mean that the rest of the rehabilitation has to be low level. They can do a lot more than you think often. Then when we're looking at the structural load, we like to keep it simple, pick an exercise and have that as a consistent progression, 1 or 2 exercises. What we like is to have an exercise that's adjustable for load, external load, because that can motivate the player, can continuously track progression of the training. We want to have exercises where we can adjust the range of movement, which may be an issue for some players, and that we can adjust the velocity as well. And these exercises will function very well to monitor pain response. So given pain at a given load can be compared week by week and even session by session. In the end, we have as a criteria for return to play that players have to be able to do the Copenhagen adduction pain-free, at least for adductor-related groin pain. Often they can do that much sooner in other players, but that's one of the things that we found is really really helpful in our decisions on when to return players safely. Additionally, it will work as a continuation exercise that most people can do anywhere regardless of equipment, and it has been shown to also prevent groin problems in general. We don't want to choose too low load exercises and exercises not targeting the adductor longus specifically. We see so many different selected exercises that are actually not targeting what we want to target. Usually in adductor related groin pain will be the adductor longus, and are not helpful for our progression. So you need to change exercises all the time. In order to get a little bit more focus on that, we want to continue to monitor strength through the rehab and monitor that we're getting the gains that we're expecting. And you can read more about strength measurements in the Aspetar journal. An article by Christian Torborg goes through some of the test methods there. Next is the functional progression. Very important thing as well. The first step is usually players will want to know when they can run. There's another good article from Anthony Hogan in the Sports Medicine Collection and in the journal online that gives you a very clear guideline as to when you want to initiate your running protocol. This is based mainly on clinical examination tests, so they have to be pain-free during a squeeze test, pain-free during modified Thomas test as well, with adduction for change direction and lifting up on a sideline bench. And I think that gives you a really, really safe approach to starting running. And I think most athletes would be able to start without issues using this approach. We believe that we can probably do it a lot sooner. Actually, we initiate running for many players before they are clinically pain-free. So we would like to have that in much sooner in that. What we use for that is basically we want to control the hip extension first. So we use a small agility ladder with controlled hip extension. So we're not getting into the hip extension, but doing fast running movements on the spot and then progressing the distance. And when they can do these simple ladder drills with 1 foot in each spot at maximum intensity, they're getting a good warm-up, a good exercise even, and they have no problems initiating the running progression. We do that as well with abduction and diagonal patterns, and that correlates well with when they're ready to start a change direction progression. The last thing that players usually do is kicking as one of the most provocative movements for football players specifically. And there are 2 good articles in the journal on this as well. One especially on the biomechanical motion and perspective on that by Lars Andersen from Denmark, and an article on how that affects some of the clinical measures as well, range of motion. But when we're looking at the kicking range of motion, we can see that when we're looking at hip abduction, we're getting far from the maximal ranges that the players actually have. Similar with hip external rotation, getting further or not reaching that maximal capacity in most players. So we don't believe that these maximal passive range of motion measures clinically are that relevant. Potentially hip extension could have an influence, but still there's no good evidence to suggest that is really a big issue in these players. The load on the adductor longus is, and we know that with seeing how many adductor injuries actually occur during kicking, and how that is provocative in long-standing groin pain as well. When we look at the kicking more detailed and the adductor longus specifically, we can see that the maximum activation occurs eccentrically in the backswing phase, where you also have the maximum rate of stretch. So that will be the time where the adductor longus is at most risk of injury. In that position, we know that the iliopsoas is a really important synergist. We can see a high muscle activation of the iliacus muscle in the backswing that continues on to the leg cocking and acceleration phase. So we believe that by strengthening the iliopsoas, we can reduce some of the load that we have on the adductor longus during the kicking. So important to include in our rehabilitation as well. Similar, we want to focus on the trunk for the anterior chain, where we know that a lot of the momentum transfers from the trunk down to the kicking foot, and that the trunk actual rotation is actually more relevant in the extension and flexion for ball velocity. And it happens quite quickly and with relatively high ranges of motion. So something that we also consider to be important in a rehabilitation and use a lot of exercises to increase focus on that. So key considerations in rehab on that regard, in the synergist muscles, the hip flexors, adductors, and trunk rotations. And we can see that corresponds well with the groin injuries in general, as we heard, inguinal-related groin pain, adductor-related groin pain, and iliopsoas-related groin pain that often coexist together with multiple entities. So we're always working with all of these muscle groups in general, regardless of whether they're painful or not. So for the synergist focus, we know that change the direction is also really important in terms of being pain provocative for groin pain. We don't have time to go through that, but basically it's the same concept. If we can strengthen the muscles that are really key for this type of movement, we can possibly reduce the load on the adductors and thereby improve function and performance and reduce some of the return to sport time as well. And that will be mainly on the posterior chain muscles that will be involved in that. So just to summarize, exercise is our first approach and load progression is key. We've seen that. We want to focus on isolated loading of the painful structures. We want to focus on an actual functional load progression. And with that, you'll have a strong base to continue your progression, but adding on synergist exercises is definitely recommended. We want to start high. Players can often do a lot more than you think, and with high I don't mean making them play football from the beginning, but finding what their individual level is so you can progress from the highest possible level. And we know from the evidence that surgery can offer good results, even though we don't believe that it's needed often. But Sarko will talk much more about that now, and we'll have some good experiences from Aspetar on that side as well. So thank you very much to the Aspetar Groin Pain Center, for Dr. Popovich and the Sports Medicine Collection guys, Ivan, for all the departments here and the guys from the center. Thank you.
Thank you, Andreas, for a nice presentation. As always, thank you for covering broadly this huge topic in only 20 minutes. I'm sure that if we could give you a chance, you could easily prepare 4 presentations and organize a workshop for everybody who is interested. So we saw that conservative treatment is not only hot and cold packs, local modalities, massage, etc. Now in 21st century, conservative treatment, physiotherapy should be based on active rehabilitation and exercise treatment, hopefully supervised by an experienced physiotherapist. So now we heard at the end that surgery is rarely needed or sometimes needed, but there are cases where we need to step in, and I will tell you something more about this. So the story of groin pain started a long time ago. First time Spinelli in 1932 in Italy described adductor pain in a fencer, and then followed by Bandini almost 10 years later, who described the groin pain in football. And then after a big gap, we had a breakthrough with Neshovic in 1967, who did the first inguinal repair. Gilmore had his modification and his theory in 1980, and also Renstrom had a paper highlighting the possible nerve entrapment. and then there were different theories in the meantime, but in 97, Ramon Cugat came with a theory of dynamic osteopathy of pubis. In 99, Professor Holmich introduced adductor exercises, which was a big breakthrough for adductor-related groin pain. In 2001, Bill Myers came up with the core muscle injury concept, and Ulrike Muschavec in 2002 published her modification of shoulder inguinal repair and allowing athletes to come back to play sooner. And there were other important topics in the meantime, but what is crucial now at the end, Ali Shin published a consensus paper basically focused on inguinal pain in 2014, and we here in Aspetar, led by Adam Weir, published a paper on groin pain terminology that we already heard about. I will not go into details. You heard so many times today, but 4 defined clinical entities for groin pain: adductor, iliopsoas, inguinal, and pubic-related groin pain. When it comes to surgeons, we are focusing mostly on inguinal and adductors. We can see that from our study, also mentioned already in the first presentation, in 100 consecutive cases, retrospective study in our clinic, that 44% of the athletes examined had multiple causes for groin pain, multiple entities, with adductor being number one on 61%. We always do a standardized examination, and which consists of palpation, passive stretching, muscle resistance. If you know the anatomy, you know which tests to use. It is not difficult to detect which entity is mostly involved. Then we come to imaging. Is it needed or not? Okay, it's useful. For adductor iliopsoas related groin pain, we can use ultrasound and MRI. For inguinal related groin pain, ultrasound, MRI, or a CT scan to detect an occult inguinal hernia. And when it comes to pubic related groin pain or hip, we use X-ray and MRIs. But we also have to understand that there's a huge number of false positive findings, and this is a study from Professor Pajanen from Finland showing that up to 48% of asymptomatic athletes have positive findings of bone stress on the pubic bone, so-called osteotis pubis, which is made probably only physiological adaptation to the load. In another study from the US in ice hockey, they found that up to 70% of athletes can have some positive findings, 36 related to adductors and abdominal wall, and a lot related to the hip, like Rinchi already said. And so we can see that don't treat the image, treat the patient. If there's no symptoms, or if you have symptoms and you just do an MRI, it can be misleading. So you have to combine the two. Probably in the future, and I hope technology will allow us to have better diagnostics with imaging, but at the moment we need to rely more on clinical examination. So, define clinical entities for groin pain. When we talk about inguinal-related groin pain, which is a case for most surgeries performed on athletes with groin pain, we already heard. I will not go into details here. This is a clinical diagnosis. You can see the pain in the inguinal canal region and tenderness of the inguinal canal. All the terms could be found in the Doha Agreement meeting. And when we look at abdominal wall, we can see that it's like a box, like a whole unit working together with diaphragm and pelvic floor. And there is some research showing that when you do a Valsalva maneuver, the rectus abdominis muscle is the least used, and internal oblique is the most used muscle. So it shouldn't be called rectus abdominis adductor complex. For me, it's more the lateral abdominal muscles, external, internal oblique, and transversus abdominis that are involved in this pathology. We all know the anatomy, 3 layers of lateral abdominal muscles forming the inguinal canal, and we have some pain in this area. And we still don't know what is the real pathology behind it. We need to prove it. There are some important nerves. For us, in this case, the most important genital branch of the genitofemoral nerve and the ilioinguinal nerve. In my experience, iliohypogastric nerve, not so much. Already in 1996, in Japan, they published a paper showing that genital branch of the genitofemoral nerve has, in up to 35% cases, cutaneous branch that can be confused with ilioinguinal, which has a cutaneous branch in 90% of the cases. Another very nice study from Senegal with 100 dissections of the inguinal canal and showing the distribution of ilioinguinal nerve. You have 16 modes of division and 8 topographic modes for presentation of the ilioinguinal nerve. So you can imagine that if you have an ilioinguinal nerve compression, you can have patients with different clinical presentation suffering from the same pathology. And we also know that it has been proven that post the point of compression, you have fat degeneration of the nerve, and which is compared to a normal nerve without compression, it's pretty obvious that this can cause pain. So when we go to literature review regarding inguinal pain causes, it starts with nerve entrapment for Enstrom in 1980, then a number of papers describing inguinal canal posterior wall weakness. Then we had some work on describing tears of external oblique aponeurosis. Some other authors talking about muscle imbalance and injury, mostly surgeons. And then last, inguinal ligament enthesopathy described by Lloyd in 2008. In my opinion, probably all of this can come together. So all of these can be causes, not one cause per se, and we shouldn't simply oversimplify this. Now, in our clinics, we can have different types of patients coming suffering from inguinal pain. It's not like they're not all the same, copy-paste. When it comes to what I would like to call nociceptive inguinal pain, you have a guy coming with deep, vague inguinal pain during or following sport, suffering from that for a long time, usually after an overload in sports. On physical examination, all structures are usually painful, all tests when you do provoke pain, and on imaging, very often you don't have any adverse findings or maybe false positive. So in these cases, usually with offloading and with good conservative treatment, exercise-based, many of them recover and they don't need surgery. You need to give them some time, up to 4 to 6 weeks, to see the results. In case if there's no positive response to conservative treatment, we go to surgery, where we do the inguinal canal reinforcement, and maybe with just passing with the needle through the muscles, we create like a dry needling effect and maybe stimulate the tissue healing in a different way. The other type of patients that we see in our clinics are what I call neuropathic inguinal pain athletes. And they would say they have sharp pain lasting for a few seconds during some movement during sport. Often they describe electricity or burning pain radiating distally from the inguinal canal. During physical examination in the clinics, very often you cannot find anything. They can be completely pain-free. If you do ultrasound, sometimes you can find posterior wall weakness. It's one element to consider, but it doesn't have to be per se the cause of pain. In these cases, in my experience, you should always start with conservative treatment because it can be like a small muscle strain that is irritating the nerve and that can resolve with physiotherapy. But you shouldn't wait too long because in these cases, surgical treatment gives excellent results, again with inguinal canal reinforcement and releasing the nerves or doing a neurectomy like we saw if you have a macroscopic degeneration and obvious compression. So I'm proud to say that from my city, Belgrade, Serbia, where I come from originally, Dr. Branko Nešić did the first successful surgery in 1967. On the left side of the slide, you can see a guy who is still alive working in the Football Federation of Serbia, and he was the first patient, who was a young 22-year-old defender at that time. So he did the modified Bassini procedure, which I know if any of my hernia colleagues are looking at this now, they're unhappy with this work because we know that you have to open the posterior wall to do a proper hernia repair or inguinal repair. But we can forgive Dr. Nešić because he was an young orthopedic surgeon who came with this idea that instead of doing a ductal tenotomy, he can do an inguinal repair and help these patients. And he had a lot of success. To honor him, we also published one of the rare articles translated in English in our Aspetar journal. You can find it online. Now, when it comes to non-mesh repairs for the inguinal canal, we know that the gold standard is the shoulder repair, which is a 4-layer continuous suture repair. And then we have the modification by Ulrike Mušavek, where she, with her modification, allowed patients to come sooner back to sports. And according to her, 67% can return to sport after 14 days. So, courtesy Ulrike Mušavek, I'll show you some videos just to have an idea what the genital branch of the genitofemoral nerve looks like below the spermatic cord. It's easy to find if you look for it. You can see also that there is no hernia. There's just like a little bit bulging. Maybe in the future this develops into a full-blown direct hernia. I don't know. Nobody did any studies on this. The repair is non-mesh repair, suture repair. And I'm happy to say I was fortunate to work with Ulrike Mušavek many times, and I utilize the same technique when I operate my patients. So, according to Ulrike's papers, return to sport following inguinal repair, like we said, 60% can go back to sport at 14 days, but only 40% are pain-free at that moment, and at even lower percentage at full exercise capacity. But we can see that 70% at 3-4 weeks are ready to play without pain, and even bigger percentage participates in sports. So we know that tissue heals, but the nervous system remembers. So we need to know that pain can persist as a result of sensitivity, not the tissue damage. We published a paper by Roald Ott and one of our colleagues here in physiotherapy department who worked with us, and with Andreas and me and Adam and the whole team, and they proposed a rehabilitation plan and return to play as a 4-stage clinical milestone-based rehabilitation program. So it's not time-related, it's a clinical milestone. You have to fulfill some criteria before going to the next step. But how it looks in practice, and this is a patient I operated recently and had rehab by Andreas, and football player, 6 days post-surgery.
Come back.
13 days post-surgery.
Go, 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 go in between. And around, and around, and around.
And 15 days post-surgery. And you have the opportunity to see the fantastic facilities we have here in Aspetar, which makes our life much easier. So, at day 22, patient is entering as a substitution.
مهرداد محمدي هينزل النجم الإيراني ينزل في وقت ظروفه وصحته وحالته تسمح انه ممكن يخلق نفسه عاليه فوق ضغط النادي العربي. تاني على طول محمد صلاح النيلي، سلام الى مهرداد. مهرداد وقف، والله خدمته، وقف على كورته تاني، عايز يعمل بالعرض.
So now we come to adductor-related groin pain and the role of a surgeon related to this. We all know that we talked about inguinal pain, and inguinal region and adductor region are closely related. And we saw in many cases in acute adductor injuries that you also had a bruise or hematoma in the inguinal region. And we know anatomically how the tendons and the aponeurosis are interconnected. And it was also described very nicely in the paper by Professor Childers with some nice dissections, free access paper if you're interested. And now I want to highlight a little bit more what we're talking about here. These are not, when it comes to long-standing adductor-related groin pain, these are not adductor strains. This is not an acute adductor injury. This is more a tendinopathy type of injury. You can compare it to a Achilles tendinopathy or some other. And very nice paper by Professor Cook, where she describes in this graph how the normal tendon responds to the load, and with reactive tendinopathy, and if you overload it, it goes to tendon disrepair. If you continue to overload it, it goes to degenerative tendinopathy, which is very difficult to treat. So it's very important to react, like Andreas already mentioned, to react on time and not to get to this last stage, because then the treatment is more difficult and the results are not so good. Also, we need to understand that when the pain is on the insertion at the pubic bone, as every insertional tendinopathy, it's much more difficult to treat than if it's the tendon itself or the muscle-tendon junction pain, which usually resolves without any surgery. So we saw that in the paper from Professor Paul Holmich in 1999, 79% of athletes come back to full capacity in 18 weeks, which is a great result. But we also know that now that 1 out of 5 doesn't return to sport. So the ideal would be to identify these athletes earlier and to see which ones are progressing good and which ones would need surgery, because sometimes you don't have 4 or 5 months to wait. In another study from 2010 by Adam Weir, he showed that comparing 2 different groups with different physiotherapy, including exercise treatment, that even in these groups, only 50% came back in 16 weeks. So we can have a lot of success, but sometimes it takes a lot of time and persistence and compliance with physiotherapy and an experienced physiotherapist who knows what he's doing. And even then, sometimes we have to step in and maybe operate on these patients. Because we know that in real life and in high-level sports, 1 month of a player being outside costs a lot of money, a big loss for him and for the club, and for him maybe for the next contract. So there's a nice paper wrote on a partial adductor release for chronic adductor-related groin pain by Professor Childers, already mentioned by Andreas. 42 out of 43 patients returned to sport in 9 weeks on average, 4 to 24 weeks altogether. I would just mention here that partial means just cutting the tendon part, not the muscle part, because if you don't cut the tendon completely, you can make the situation even worse. Now, another paper by US on surgical technique, completely described, very nice paper with the proposed rehabilitation plan, and also a similar timeline to return to sport. Now, one of my patients from a few years ago who had bilateral inguinal repair and bilateral adductor tenotomy after not playing football for 1 year and not improving for 3-4 months here with us in physiotherapy, and this is 5 weeks post-op. So 4 surgeries done at once, and you can see that there's a huge improvement, big difference. And so surgery in selected cases, when it's done correctly, can give good results. So take-home message: you need to know your anatomy, precise diagnosis, and correct terminology. You need to have structured strengthening rehabilitation, criteria-based progression. It's useful to use questionnaires and baseline strength values so you can monitor your progression. 2 to 3 out of 10 pain is okay during rehabilitation. You need to give them sufficient recovery time. It's sport-specific tailored rehabilitation, so functional movements. Adductor enthesopathy, possible surgery. Tendinopathy, no surgery. Neuropathic inguinal pain, early decision on surgery. Nociceptive pain, delay surgery. So it's what you learn after you know it all that counts, like John Wooden said, and we should trust him. So I'm happy to say that all these webinars will be available on Aspetar Sports Medicine Collection online form on the YouTube, Aspetar channel, and you can follow us on Twitter, and we are open for future mutual collaboration and working together. Thank you very much. Thank you. Changing seats. So now we came to the end of our today's webinar. I'm proud to be working with this fantastic group of people. You had one English guy living in Holland and 2 Dutch guys at the beginning, and all of them spent part of their life in Aspetar working with us, and we're still collaborating closely. And of course, my friend Andreas, who is like my teammate on a daily basis. I would like to thank Professor Popovic and with Ivan Stankovic and Nassim and the rest of his team for making these textbooks, this fantastic collection of empiric knowledge, and I'm sure that everybody will find it helpful. all attendees can download the electronic form of this chapter in the next couple of days, and it will be pretty soon available, the whole collection, online for free. It's intended to improve the way we treat our athletes and to share knowledge. I'm happy also to invite you to join us for the next webinar, which will be in 1 month, also with a fantastic speaker lineup, and the topic of the webinar will be team physician in different sports. Thank you very much for being with us today. I hope you had a nice 2 hours and that we managed to transfer some information that we believe is right. And I think that a lot of work is still ahead of us to improve our knowledge and our treatment. Thank you very much.